This model of the human lower gastrointestinal tract represents a massive spectrum of benign bowel disorders. To manage them effectively, we have to look past the presenting symptoms and understand the specific anatomical and functional failures at play. We are going to deconstruct the exact clinical diagnostic criteria, strict surgical thresholds, and hemodynamic classifications required to master these pathologies. We will divide this into 3 core pillars. The first pillar covers mechanical diversion and surface area loss, examining the mechanics of stomas and the functional deficits of short bowel syndrome. The second pillar targets vascular and structural failures, focusing on the origins of lower gastrointestinal hemorrhages and the progression of diverticular disease. The third pillar encompasses inflammatory, infectious, and complex sequelae, mapping out inflammatory bowel disease, bowel tuberculosis, and the anatomical challenge of fistulas. Accurate clinical differentiation within these 3 pillars dictates the endpoint of patient care, definitively establishing when to intervene with surgery and when to rely on conservative management. A stoma is a surgically created opening that brings the bowel onto the abdominal wall. These serve 2 functions. A temporary stoma acts as a diversion to protect a distal anastomosis and is typically closed after 8 to 10 weeks. A permanent stoma is required when restoring bowel continuity is anatomically impossible. The primary indication for a permanent stoma is an abdominoperineal resection, or APR. This operation is mandated for rectal carcinoma located less than 5 centimeters from the anal verge. Anterior mapping shows precise anatomical siting for diversions. Stomas must be placed away from bony prominences, scars, and skin folds. An ileostomy is routed to the right iliac fossa. A sigmoid colostomy goes to the left iliac fossa, and a transverse colostomy utilizes the epigastric region. We identify stoma architecture visually. An end stoma brings one bowel end to the surface, leaving a single opening. A loop stoma delivers an intact bowel loop, creating 2 connected openings. A double-barrel stoma brings 2 ends out separately, leaving 2 non-joined openings. The segment of bowel used dictates the stoma's physical profile. Ileostomies produce a high volume of corrosive liquid output. To prevent skin excoriation, the ileostomy is constructed with a pouting architecture that directs effluent directly into the bag. Colostomies produce a lower volume solid output that is less irritating, so they are left flush to the skin. Surgical intervention carries risks. The earliest complication is tissue necrosis, driven by vascular compromise from a tight fascial opening. However, skin excoriation remains the most common overall complication, particularly with ileostomies. Late complications include prolapse, retraction, and herniation. The peristomal hernia is the most frequent long-term complication of a colostomy. It occurs more often in loop stomas than end stomas, and definitive treatment requires a surgical mesh repair. Short bowel syndrome is a severe malabsorptive state developing when residual small intestine falls below 200 centimeters. Above 100 centimeters, patients are net absorbers. Below 100 centimeters, patients become net secretors. At this threshold, fluid and electrolyte losses actively exceed absorptive capacity. The most common cause of this massive bowel loss in adults is a superior mesenteric artery embolism, followed by resections for Crohn's disease and physical trauma. In pediatric patients, it is primarily caused by intestinal malrotation and atresia. The location of the lost bowel matters immensely. The ileum can undergo structural adaptation to compensate if the jejunum is removed, but the reverse is not true. The jejunum cannot adapt adequately to the loss of the ileum, predisposing the patient to significant nutritional deficits, particularly vitamin B12 deficiency. Preserving the ileocecal junction is a critical surgical priority. An intact junction creates a mechanical delay in transit time, forcing the remaining bowel to maximize its limited absorptive window. Baseline medical management relies heavily on total parenteral nutrition, or TPN, and targeted medical therapies like teduglutide. Small intestinal transplantation remains an option, but reliable results are strictly limited to specialized transplant centers. To mechanically increase transit time, surgeons utilize specific bowel lengthening procedures. The Bianchi procedure splits a dilated bowel segment longitudinally and tubularizes the halves end to end. This increases length, but directly narrows the lumen and introduces a severe risk of compromising the blood supply. The STEP procedure, or serial transverse enteroplasty, solves this vascular problem. Surgeons apply linear staplers in an alternating pattern from the mesenteric to antimesenteric borders. This creates a zigzag channel that slows transit and increases absorptive opportunity, bypassing the vascular risks of the Bianchi split. This cross-section highlights diverticular disease. Most colonic diverticula are false diverticula, a mucosal protrusion piercing the muscular wall along the mesenteric vascular border. In contrast, a true diverticulum, like Meckel's, involves all bowel layers and sits on the opposite, antimesenteric border. Uncomplicated diverticulosis describes the presence of these pouches without active inflammation. It typically presents in a patient's 4th or 5th decade, occurs most frequently in the sigmoid colon, and is diagnosed by a classic sawtooth appearance on a barium enema. The clinical profile shifts entirely when these pouches become inflamed, resulting in diverticulitis. Patients present with left-sided abdominal pain, diarrhea, fever, and a raised total leukocyte count. At this stage, a barium enema is absolutely contraindicated due to a high risk of lethal bowel perforation. The strict investigation of choice for active diverticulitis is a contrast-enhanced CT of the abdomen. The Hinchey classification dictates the intervention. Stages 1 and 2 denote colonic inflammation with localized pericolic or pelvic abscesses. These are managed conservatively with bowel rest, IV antibiotics, and image-guided percutaneous drainage utilizing a pigtail catheter. Progression to Stage 3 purulent peritonitis or Stage 4 fecal peritonitis breaks conservative thresholds, mandating an emergency laparotomy. The standard surgical response is Hartmann's procedure, resection of the diseased sigmoid colon, creation of a proximal colostomy, and closure of the distal stump. Reversing the colostomy is considered after 8 to 10 weeks. This neutralizes the long-standing risk that severe diverticular disease predisposes the patient to colorectal carcinoma. Diverticular disease is the single most common cause of massive lower gastrointestinal hemorrhage. While diverticula are most common in the left-sided sigmoid colon, right-sided diverticula, fed by superior mesenteric artery branches, are more prone to severe bleeding. The second most common cause of massive lower GI bleeding is angiodysplasia. These are dilated vascular lesions typically found in the cecum of elderly patients. When angiodysplasia presents alongside aortic stenosis and an acquired von Willebrand factor abnormality, it forms the clinical triad known as Hyde syndrome. This flowchart tracks lower GI bleeding evaluation. Step 1. Exclude local anorectal causes like hemorrhoids. Step 2. Stabilize with IV fluids. Step 3. Perform a colonoscopy. If negative, Step 4 mandates an upper GI endoscopy, as brisk upper bleeds can present as hematochezia. If both endoscopies are negative, you reach Step 5, obscure GI hemorrhage. The source is presumed to be in the small bowel. Diagnostic tools scale up to capsule endoscopy, CT angiography, and the highly sensitive technetium 99M per technetate scan, which can detect bleeding rates as low as 0.1 milliliters per minute. The patient's immediate hemodynamic state dictates the path. Stable patients receive the stepwise colonoscopy first, but actively bleeding patients presenting in shock bypass endoscopy entirely. They require immediate CT angiography and prompt embolization, with surgery reserved only for when embolization fails to halt the vascular loss. Inflammatory bowel disease primarily splits into Crohn's disease and ulcerative colitis, and they present with exact opposing demographic risk profiles. Crohn's disease is more common in females, peaking in their 20s to 40s, and risk is directly increased by smoking. Ulcerative colitis favors males in their late 20s to 40s, and surprisingly, smoking acts as a protective factor. This split screen compares their gross anatomical differences. Crohn's disease features transmural inflammation, penetrating the entire bowel wall, creating strictures and non-continuous skip lesions. Ulcerative colitis is strictly limited to the mucosa and submucosa. It begins in the rectum and spreads proximally in a continuous, uninterrupted pattern. Crohn's disease possesses a distinct morphology, characterized by a cobblestone mucosal appearance, creeping fat, and severe perianal fistulas. These require the placement of setons. The pathology also has a strong genetic association with the NOD2/CARD15 mutation. Active Crohn's disease frequently presents with right lower quadrant pain, perfectly mimicking acute appendicitis.
If a surgeon opens the abdomen and discovers active Crohn's, an appendectomy must be strictly avoided. The inflamed tissue heals poorly, and removing the appendix severely risks creating a postoperative fecal fistula. Ulcerative colitis presents bloody diarrhea, friable mucosa, pseudopolyps, and microscopic crypt abscesses. While it is limited to the colon, the terminal ileum can exhibit retrograde inflammation known as backwash ileitis. UC carries a high risk of toxic megacolon, defined as a lethal colonic dilation exceeding 6 centimeters. It is managed rapidly with NPO status, IV fluids, antibiotics, and decompression. If the patient does not respond, or if severity escalates to fulminant, over 10 stools a day, surgical resection is required. Both diseases trigger extraintestinal manifestations, like erythema nodosum, ocular uveitis, and renal stone formation. Most resolve after a diseased colon is removed, but there is a crucial exception. Primary sclerosing cholangitis and ankylosing spondylitis persist and do not improve after definitive bowel surgery. These pathological borders dictate surgical endpoints. Crohn's disease allows for no definitive surgical cure because skip lesions recur. Management is strictly conservative. Ulcerative colitis allows for a definitive cure through a total proctocolectomy with ileal pouch anal anastomosis, or IPA. This creates a J-shaped ileal pouch, a technique also utilized in familial adenomatous polyposis, though patients face long-term risks of pouchitis. Abdominal tuberculosis operates through distinct anatomical vectors and is diagnosed strictly by obtaining tissue for Zeal-Nielsen staining, followed by anti-tubercular therapy. Peritoneal TB presents with peritonitis and pyoperitoneum, leaving thick pus that causes severe surgical adhesions. Omental TB causes tissue to bind into omental caking, presenting as a mass that closely mimics advanced malignancy. Intestinal tuberculosis manifests in 2 distinct forms. Ulcerative TB occurs with a weak immune response and primarily affects the terminal ileum. Hyperplastic TB occurs with a strong immune response, producing a localized mass lesion specifically in the ileocecal region. We can differentiate infectious bowel pathologies by ulcer morphology. Tuberculous ulcers orient transversely across the bowel lumen. Because they wrap around the circumference, they contract as they heal, creating fibrotic strictures and mechanical obstruction. In direct contrast, typhoid ulcers orient longitudinally, running parallel to the ileum. They do not typically cause strictures, but they are highly prone to rupture, usually triggering a catastrophic perforation during the 2nd or 3rd week of infection that requires an emergency laparotomy. A patient with hyperplastic ileocecal TB will present with pain, weight loss, and a palpable mass in the right iliac fossa. If this mass persists after a month of targeted therapy or causes a full obstruction, a right hemicolectomy is required. Radiologically, these infections leave distinct architectural damage. Fibrotic narrowing of the terminal ileum appears as the string sign of Cantor. The contraction of the ileocecal tension, combined with proximal dilation, produces the classic gooseneck or swan neck deformity. Severe inflammation or operative damage can result in a fecal fistula, an abnormal communication allowing intestinal contents to leak externally. A high-output fistula leaks more than 500 cc's per day. A low-output fistula leaks less than 200 cc's per day and can close spontaneously. Spontaneous closure requires an optimized environment. We utilize the FRIEND mnemonic to identify absolute barriers to closure: foreign body, radiation, inflammation, epithelialization, neoplasm, and distal obstruction. Surgical management is bound by the mandatory SNAP protocol. You must ensure skin and sepsis control, deploy aggressive nutritional support via TPN, define the exact internal anatomy, and delay the planned procedure until the patient is physiologically optimized. Rushing risks compounding the injury. Differentiating these benign bowel disorders requires absolute precision. Both Crohn's disease and bowel TB cause terminal ileal strictures, weight loss, and the string sign of Cantor on imaging. Because their physical footprint overlaps, differentiation relies entirely on pathological biopsy and extraintestinal clues. Stoma identification follows strict structural rules. One opening is an end stoma. 2 joined openings indicate a loop stoma. 2 separated openings indicate a double barrel stoma. Pouting architecture implies an ileostomy. Flush architecture implies a colostomy. Stoma complications track on a specific timeline. Necrosis is the earliest failure point. Skin excoriation is the most common overall complication. And the peristomal hernia is the most frequent long-term failure for colostomies. Clinical thresholds are absolute. Short bowel syndrome initiates under 200 centimeters of residual bowel. Net secretor status triggers under 100 centimeters. Toxic megacolon is defined by a colonic dilation exceeding 6 centimeters. High output fistulas exceed 500 cc's of daily fluid loss. Massive lower GI bleeds have a strict hierarchy. Diverticular disease is the undisputed most common cause. Angiodysplasia ranks second. Imaging modalities depend strictly on the state of inflammation. Uncomplicated diverticulosis is mapped safely with a barium enema. Active diverticulitis strictly prohibits barium and mandates a CECT to prevent lethal perforation. Microscopic inflammatory patterns dictate surgical limits. Crohn's causes transmural damage. Ulcerative colitis remains mucosal. Typhoid ulcers rupture linearly along the bowel. Tuberculosis ulcers strike transversely, causing fibrotic strictures. The chaotic presentations of benign bowel disorders are entirely subdued by mastering these precise anatomical measurements, specific hemodynamic thresholds, and rigid pathophysiological boundaries.